This is Clearly Community, a public affairs program of Clear Channel Radio.
Welcome to another edition of Clearly Community. My name is Rod Cackley. I'm the news director at News Radio Wood 1300. And to begin today's show, we're going to talk about Faith Hospice with Dr. John Mulder. He's the Vice President of Medical Services at Faith Hospice. John, thanks for coming down. I appreciate it.
Delighted to be here, Rod. Just appreciate the opportunity.
Let's begin by doing some background. Let's talk about Faith Hospice. I know that in 95, Holland Home started Hospice of Holland Home. The name changed to Faith Hospice in 2006. Why did that happen? Give me some background on the organization.
Well, there's a couple of reasons that we looked at name change at that particular point in time. One was kind of pragmatic. Just to our west, we have Hospice of Holland, a wonderful organization that works out of the Holland area. And there was a little name confusion, Hospice of Holland Home. But that was really kind of the minor issue. We really wanted to portray our faith basis as important. We also wanted the community to know that we as an organization were available to the entire community, not just the Holland Home community. Holland Home, as you may know, is a collection of a number of different wonderful resources here in the Grand Rapids area. We have 3 different campuses of continuous care with nursing homes and assisted living, independent living. And the hospice was originally started to serve that population. Recognizing that we had an opportunity to serve the greater community then, the hospice expanded over the years, and we just felt that the name reflected both our mission as well as a more widespread ecumenical approach to care.
I think we should talk about the word hospice. Before we turn the microphones on, you expressed a desire to do that. I have some familiarity with it because we used hospice for the last days of my mom's life.
Exactly right, and there is some misconceptions and actually a lot of fear. A lot of times when I use the word hospice with patients, you kind of just see the hair stand up on the back of their neck because historically a lot of people have seen this as just something that happens in the last days. And truly what hospice really is designed to do is to provide an opportunity to bring a team together to help to support patients and families who are dealing with, in many circumstances, one of the most difficult parts of their life journey. But it is designed to improve the quality of life, to allow people to truly live. I have patients all the time where people come up to me from time to time and say, boy, I don't know how you could do what you do dealing with dying patients all the time. And I tell them, I said, the last I checked, all my patients are still living. And the goal really is to provide abundant life, wonderful life, peaceful life, to allow them to help to find joy and to achieve goals and to really realize their dreams, knowing that life is short. Hospice does imply that we have a limited life expectancy. But the reality is that most of us at some point in time are going to know that our lives are limited.
We're talking to Dr. John Mulder. He's the Vice President of Medical Services at Faith Hospice. This is Clearly Community. My name is Rod Cackley. You used an interesting phrase, life journey. Talk to me about that. What does that mean when you say life journey?
In our advanced technological society, we sometimes, I think, consciously delude ourselves into thinking that we're going to live forever.
Sure.
But life has a defined beginning and it has a defined end. And most of us, some people would estimate as many as 90% or more, are going to be given at some point in time a condition, a disease, a circumstance, some label that we know is going to define the end of our life. It might be something as major as a cancer. It might be something like heart disease or kidney failure or something like this that may not have the imminence and the emotional impact of something like cancer, but we know that ultimately is going to show up on our death certificate. If we understand and know that life is limited, would we not want to do what we can to make the most out of the time that we have left? And so when we talk about life journey, it really is in phases. There's a different approach that we take to life in our youth and in our middle adult years, and in our later adult years. There's a different approach that we take when we know that we are, in fact, mortal. Sometimes that trajectory gets pushed way up when we have people who are in their 20s and their 30s who have really bad diagnoses, and we know that they're not going to survive but maybe a few months or maybe a few years. What hospice does is to come in and say, we recognize the fact that you may only have a few months to live. What do you want to get out of life? I ask the doctors sometimes, I said, if you knew for certain here in August of 2010 that you will not see Christmas this side of heaven, would you not live your life differently today? So part of when we talk about the life journey, it's about truth-telling. It's about being realistic about what we've got going on and what that really means. Bringing technology and medical services in when they have the opportunity to sustain life and to sustain meaningful life, but not just to prolong a meaningless existence. So the life journey kind of incorporates a lot of factors that relate to quality of life and the meaningfulness of life.
How do you incorporate the family of the patient into this?
Well, when we talk about end-of-life care, the family's absolutely instrumental in that, and they need support as well. Hospice is delivered by a team approach. So we have a nurse that kind of quarterbacks the team. We have the medical director, the physician who is involved. We have home health aides that come in and assist with personal care. We have social workers that come in and help with sometimes something as pragmatic as funeral arrangements and what do we want. But in many circumstances, the social workers play a very vital role in helping to negotiate sometimes complex relationships to help families prepare for that. Especially we have perhaps a younger patient and they have adolescents or even younger children at home. How do we help these children understand what's going on? The team then helps the family adjust, come together, reconcile damaged relationships or support positive relationships to really access the positive resources of the families and really kind of push to the background those patterns of behavior or things that may not have been all that productive in someone's family. How can we bring out the best in the family to help support the patient through the last days? We're
talking to Dr. John Mulder. He's the Vice President of Medical Services at Faith Hospice. There's so much I'd like to talk to you about, Dr. Mulder, but we should say that you are a nationally recognized authority on end-of-life issues and pain management, sought-after speaker on those topics, also certified as a hospice and palliative medicine specialist by the American Board of Hospice and Palliative Medicine in 2000. Tell me, now, one of the questions I had was, is hospice static or changing? Is it evolutionary? And then you brought up, I think I'm pronouncing that right, palliative medicine.
Correct.
What is palliative medicine, and is that a change in the hospice approach or attitude?
Well, I think I can wrap all that up in one. And my kudos to whoever wrote that for me. And nationally recognized sounds awfully impressive, doesn't it?
It does sound good.
I do have the opportunity to do a lot of speaking around the country, but part of it is that there's not that many of us around. I would say that an approach to compassionate end-of-life care has been around for millennia. People have been dying as long as people have been on this earth, and there have always been those who understand that there has to be a compassionate approach to the care of these individuals who are experiencing their last days. And so the attitude has been there. What has happened over the years is that there has been perhaps a more sophisticated and a more formal way of amalgamating those services. What happened, I think one of the biggest changes was in 1982 when the government actually did something really, really positive in healthcare, and they passed the hospice Medicare benefit, and that provided a funding stream for hospice services. Prior to that time, you would have nurses and chaplains and social workers, rarely docs, who would help to provide in a volunteer capacity hope and help to the dying. And so once the hospice Medicare benefit came in, now you had the opportunity to define specific menus of services and resources that are available and should be provided, and if you are Medicare certified, have to be provided to patients and families. So when that kicked in, now you started to see a proliferation of hospices to the point that there's estimated between 4,000 and 5,000 hospices across the United States now. They vary in size, they vary in character, but they all have the basic core services of nurse, physician, home health aide, volunteer services, social work, chaplaincy services that are provided to the patient and the family. The government keeps trying to tweak the regulations to try to make sure that we're doing the best that we can with the resources we have available, and so you do see some evolution in the development of hospice providers. We're fortunate to have a half a dozen or so hospice providers here in West Michigan. Well, here in the Grand Rapids area, with more outside of the Grand Rapids area that provide really, really excellent services. The issue of palliative medicine then was a kind of a logical extension of this. I would say beginning probably in the late 80s, perhaps early 90s, physicians more and more became committed to a line of practice that focused on improving the quality of patients' lives when they have life-limited or life-threatening conditions, or I sometimes refer to them as life-defining illnesses. And so that's I think it was probably 1997, the American Board of Hospice and Palliative Medicine was formed with doctors who were committed to this, and we began certifying physicians at that particular point in time. That has grown to the point where we are now a recognized specialty by the AMA, American Board of Medical Specialties. Our training programs are accredited by what's called the ACGME, which accredits all medical training programs. And so we are now a legitimate card-carrying subspecialty of medicine. There's perhaps maybe only 3,000 or 4,000 of us across the country, so there's not that many of us yet. But we're growing, and the need for these services are growing as people recognize that that quality care, that compassionate care, that comfort is not only possible but desirable. We, as palliative physicians, like to point out that palliative medicine is not hospice. Sometimes I will have folks come to me and they'll say, we were going to seek palliative, but we weren't ready yet. Mm-hmm. Well, that I can understand if you thought there was prognostic limitations that would be valid. But in truth, anytime you have a condition that we can't fix, we can't cure, then palliative is a very, very relevant discipline to bring into play. I've participated in the lives of children with cystic fibrosis who I expect to long outlive me, who had need of palliative services so that they could participate in sporting events, so their lives could be improved, their symptoms could be controlled, and they could experience wonderful quality of life. People with degenerative neurologic diseases, yes, they may not have an imminent death, but we can see that on the horizon, and to allow them to achieve their goals, dreams, and maximal function now. Or it might be someone young with leukemia who is in the midst of devastating chemo treatments that are really kind of trashing their symptoms, and they have just really lousy quality of life. There are things that palliative medicine can do to help to improve their quality of life while they're going through this particular part of the journey.
We only have a couple of minutes left. Our time's running out already. I wanted to talk about how attitudes are changing. Can we talk about that a little bit? Inside the institutions or the hospice organizations and outside, what have you seen?
Well, fortunately, we're seeing much greater acceptance of palliative services, so that physicians and healthcare systems are much more likely to accept that. St. Mary's is, for many years, has had a very strong palliative care program in the hospital. Spectrum is in the process of developing a very, very fine palliative care program as well. So we're seeing the hospital systems accept this as an essential component of the care that they deliver to their patients. People still tend to be death-denying, and it's still sometimes a challenge for people to accept the reality of their terminal condition. What I tell people all the time is that we know we have something we can't fix. Let's make sure we've got the proper resources to help you deal with that at this particular point in time. And if life is limited by some number of months because of your diagnosis, then let's get hospice involved to help you with this part of the life journey. Is
that the time to get hospice when you find out you or a loved one have when the end is going to be, so to speak?
Yes, I think that when we have a defined prognosis that is limited by months, that's a wonderful time to get hospice involved. Let's not wait till the last few days or hours or the minutes. I've seen people who have been in hospice service for 15 minutes. You can't do a lot of work or achieving of goals if you have that little time. So the sooner, the better.
And how do you get started? How do you get in touch with Faith Hospice if that's how you decide to go, or you want to find out more?
Well, find out more. We have our telephone numbers, area code 616-235-5113, and that will get you to our central intake, and they can give you all the information that you'd like about hospice eligibility, about questions or concerns. I'll put you in touch with a nurse who can talk to you about what's going on, about yourself or family member, or just if you have curiosity. Also, you can go to website is hollandhome.org, and you can click on links to hospice there.
Dr. John Mulder, Vice President of Medical Services at Faith Hospice. Thanks for coming down today, Doctor. I appreciate it.
Well, thank you, Rod. Just really appreciate the conversation.